عليكم ورحمة الله وبركاته. الحضور الكرام جميعا، نرحب بكم في هذه الأمسية العلمية الثالثة التي تقيمها كلية الطب جامعة نينوى. وطبعا هي فرصة طيبة أن نلتقي في هذا اليوم المبارك، عيد الأضحى المبارك. نتمنى للجميع عيد سعيد، ونسأل الله سبحانه وتعالى أن يزيل هذه الغمة عن الجميع وترجع الحياة إلى طبيعتها إن شاء الله. اليوم راح تكون يعني لقاء مميز بحضور مميز إن شاء الله. طبعا هو اللقاء برعاية السيد عميد كلية الطب نينوى، اللي أبلغ تحياته لكم وأناب عنه الأستاذ المساعد الدكتور نشوان الحافظ، معاون العميد للشؤون العلمية. تفضل دكتور نشوان.
السلام عليكم ورحمة الله وبركاته. السادة الحضور المحترمون، مع حفظ المناصب والألقاب، نيابة عن السيد العميد الأستاذ المساعد الدكتور أسامة المشهداني المحترم، أهنئكم بعيد الأضحى المبارك، وكل عام وأنتم بكل خير وصحة وعافية. من دواعي سرورنا أن تواصل كليتنا هذا النشاط العلمي الإلكتروني، وأن تستفيد من خبرة الأساتذة من خارج وداخل العراق لإغناء العملية التعليمية وديمومة تحديثها. نتمنى لهذه الجهود الحثيثة بقيادة عميد كليتنا المحترم لترتقي كليتنا وجامعتنا إلى ما تصبو إليه، وبنفس الوقت أن نديم التواصل مع إخواننا في جامعة الموصل وجامعة المستنصرية والجامعات العراقية الأخرى في الفعاليات والنشاطات العلمية للارتقاء بجامعاتنا، ومن الله التوفيق. أترك الكلام لأخي الدكتور نزار المحترم للبدء بإدارة الفعالية، وشكرا.
شكرا جزيلا دكتور نشوان. وطبعا مثل ما تفضل دكتور نشوان، يعني تأتي هذه الفعالية ضمن يعني سعي كلية طب نينوى لتحسين وتنمية المهارات التدريسية لأعضاء الهيئة التدريسية في الكلية لدينا، من خلال القيام بفعاليات ومحاضرات علمية بالاشتراك مع أساتذة مميزين من جامعات أخرى ومن خارج القطر. The talk of today اللي هو update in the management of bronchial asthma in pediatric. We will have three distinguished speakers. Two of them from the Department of Pediatric at Nineveh Medical College, and the third is a distinguished speaker Dr. عمار احمد سعدون، استشاري طب الأطفال والتدريسي في جامعة ألاباما. طبعا هو دكتور عمار هو أحد أبناء المدينة، وهو أيضا من خريجي كلية الطب جامعة الموصل، واللي تغرب ومر بالعديد من المراحل وانتقل إلى أوروبا وتدرج إلى أن انتهى به المطاف في جامعة ألاباما، وحصوله على اختصاص دقيق في أمراض الرئة لدى الأطفال Pediatric Pulmonary in Pediatric Pulmonary. Now the first speaker will be Dr. Ahmad Khaleil, a specialist pediatrician from the Department of Pediatric at Nineveh College. He will speak about bronchial asthma definition and etiology. Please, Dr. Ahmad.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته، وعيدكم مبارك وكل عام وأنتم بخير. ورحب بالسادة الحضور، أساتذتي، زملائي الأعزاء، أعزائي الطلبة. My lecture today will be some point about introduction about asthma. العفو دكتور نزار، ممكن سكرين شير؟
دكتور نشوان, can you please open the screen?
دكتور عيني تفضل.
Pediatric asthma. Childhood asthma is a chronic inflammatory condition of the lung airway resulting in episodic airflow obstruction. Childhood asthma is among the most common causes of childhood emergency department visit, hospitalization, and missed school days. Presentation of childhood asthma, sign or symptom, may be presented with shortness of breath, difficulty in breathing, dry cough, night cough and sleep disturbance, wheezing, or chest pain and tightness. One or more of these sign or symptom. As epidemiology, childhood asthma appear to be increasing in prevalence despite considerable improvement in asthma management. Asthma prevalence correlated well with reported allergic rhinoconjunctivitis and atopic eczema prevalence. An area where there is an increased incidence of eczema or conjunctivitis, allergic rhinoconjunctivitis, there is an increased incidence in asthma prevalence. A disparity in asthma outcome links high rate of asthma hospitalization and death with poverty and urban living as a result of overcrowding, poor housing condition, poor compliance and follow-up from the patient, and environmental exposure to toxin, pollutant, and so on. Approximately 80% of all asthmatic patients reported disease onset prior to 6 years of age and the first 2 years of life. However, of all young children who experience recurrent wheezing in the early life, only a minority go on to have persistent asthma in later childhood. Maybe up to 1/3 of these patients will have persistent asthma in adulthood. In this, we have world map of prevalence of clinical asthma from about 90 countries all over the world, colored with red in the area where there is high prevalence of asthma, such as USA, UK, where there is maybe more than 25 to 30% prevalence of asthma, high incidence in the UK. In the country in the orange have incidence between 7 and 10. In the yellow, there is between 5 and 7. Green, between 2 and 5, such as Algeria. In the blue color, there is between 0 and 2 to 2.5. Our country, Iraq, and other countries in the Africa and some countries in the Asia, we do not have standardized data available for prevalence of asthma. Risk factor for persistent asthma. The risk factor for persistent asthma into adolescent and adult life can be divided into 2 groups. First of all, major group, which include parent asthma, eczema, inhaled allergen sensitization, and we have a minor risk factor for persistent asthma, which include allergic rhinitis, wheezing apart from cold, 4% peripheral blood eosinophil, food allergen sensitization. From these, allergy in young children with recurrent cough and wheezing is the strongest factor for persistent of asthma. This is the most important risk factor for persistent asthma into adulthood and adolescent. The early presentation, the more severe presentation, and recurrent attack is usually the strongest factor for persistent of asthma. Etiology. Till now, the cause of childhood asthma has not been determined, but usually a combination of environmental exposure and inherited biologic and genetic factor has been implicated. In this figure, we have the etiology of asthma as a combination of environmental factor from air allergen, infection, usually viral, microbes, pollutants, stress factor, and biological and genetic factor. And with the age of the patient, we have innate and adaptive immune development atopy with respiratory viral infection and air allergen exposure and environmental tobacco smoke and pollutant toxicant will lead to lower airway injury. With this persisting will lead to remodeling and airway and will lead to asthma. In susceptible hosts, immune response to common airway exposure, such as respiratory virus, allergen, tobacco smoke, air pollutant, can stimulate prolonged pathogenic inflammation and apparent repair of injured airway, lead to lung dysfunction, airway hyperresponsive, reduced airflow, and airway remodeling. In this picture, we have some of the asthma trigger: mold, pit, dust, mold dust, smoke, chemical odor, such as now from bleach and alcohol, grass and weed, and cockroaches. In this picture, we have normal airway. We can see the bronchiole have wide diameter, thin wall, normal alveoli. In the asthmatic airway, there is an inflamed and thick wall and an decrease in the lumen of the bronchiole. This is normal asthmatic. During attack of asthma, there is an increase in the thickening of the wall as a result of edema, an inflammatory cell, an increase in mucus production. This will lead to narrowing of the lumen of the bronchiole with the constriction of the smooth muscle of the bronchiole, and will lead for air trapped in the alveoli, and this will result in the dyspnea and wheezy chest and so on. And thank you.
شكرا جزيلا Dr. Ahmed. Thank you very much for this nice introduction about the types, definition, and etiology, about the etiology and definition of asthma. Now, we will have Dr. Ru'a Faisal, another pediatric specialist from the Department of Pediatric at Nينوى College, who will talk about the classification of bronchial asthma. تفضل دكتور رؤى.
نعم دكتور. السلام عليكم ورحمة الله وبركاته. في البداية كل عام وأنتم بخير. أعاده الله علينا وعليكم بالخير واليمن والبركات. سائلين تعالى أن يرفع هذا الوباء على العالم أجمع. My lecture about the classification of asthma. Before starting the classification of asthma, we should know the most important clinical manifestation of asthma in the pediatric age group. The intermittent dry coughing and expiratory wheezing are the most common chronic symptoms of asthma. Older children and adults report associated shortness of breath and chest congestion and tightness. Younger children are more likely to report intermittent non-focal chest pain. The respiratory symptoms can be worse at night, associated with sleep, especially respiratory infections or inhalant allergies. The daytime symptom often linked with physical activities, exercise-induced, or play that are reported with the greatest frequency in children. Now, the classification of asthma. The National Asthma Education and Prevention Program has classified asthma as intermittent asthma, mild persistent asthma, moderate persistent asthma, and severe persistent asthma. These classifications are based on the severity, which is determined by the symptoms and lung function test. The classification is based on symptoms before starting treatment. The classification may be changed over time. A person in any category can have severe asthma attacks. Asthma in children that younger than 4 years hard to diagnose, and its symptoms may be different from asthma in older children or adults. Intermittent asthma. Asthma is considered intermittent if without treatment any of the following are true. The symptoms, which is divided into the daytime symptoms and nighttime symptoms. The daytime symptoms for intermittent asthma occur in fewer than 2 days a week. These symptoms don't interfere with normal activities. The nighttime symptom for intermittent asthma in those aged less than 4 years, there is no nighttime symptoms. And for those more than 5 years, the symptom at night occur in fewer than 2 nights a month. The lung function test of the intermittent asthma is normal, with forced expiratory volume is more than 80% of a predicted value, and there is a little variation in the peak expiratory flow, which is less than 20% from morning to afternoon. Mild persistent asthma. The symptoms of mild persistent asthma in the daytime occur in more than 2 days a week, but not daily. There is a minor limitation of daily activities. The nighttime symptom of mild persistent asthma in those aged less than 4 years is 1 to 2 times a month, and for those aged more than 5 years is 3 to 4 times a month. About the lung function test in the mild persistent asthma is also normal, with forced expiratory volume is the 80% of predicted value, and the peak expiratory flow variation is 20 to 30% from morning to afternoon. Moderate persistent asthma. The daytime symptoms of moderate persistent asthma occur daily, so that the inhaled short-acting beta-2 agonist should be used daily for these patients. And there is some limitation of daily activities. The nighttime symptom of moderate persistent asthma in the age less than 4 years occur in 3 to 4 times a month, and for those aged more than 5 years it occurs in more than 1 time a week, but not nightly. The lung function test for moderate persistent asthma is abnormal, with forced expiratory volume 60 to 80% of a predicted value, and the peak expiratory flow varies more than 30% from morning to afternoon. Severe persistent asthma. The symptoms of severe persistent asthma in the daytime occur throughout each day. يعني على مدار اليوم تكون عندهم الأعراض of asthma. There is a severely limited daily physical activity. The nighttime symptom, severe persistent asthma in those aged less than 4 years, is more than 1 time a week, and for those aged than 5 years, often every night. The lung function test of severe persistent asthma is abnormal, with forced expiratory volume is less than 60% of predicted value, and the peak expiratory flow varies more than 30% from morning to afternoon. The risk of the asthma exacerbation that requires systemic corticosteroid. For intermittent asthma, there is no to 1 attack of the exacerbation per year. For persistent asthma بأنواع mild, moderate, and severe, either there is 2 or more than 2 exacerbations in 6 months that require systemic corticosteroid, or 4 or more than 4 wheezing episodes per year, lasting for more than 1 day, and with risk factor of persistent asthma. هذاك كان ال classification depends on the severity of symptoms اللي هو الأكثر ال classification نعتمد عليه. أكو another classification هو ال control classification. The clinical assessment while asthma being managed and treated قسموها إلى well controlled, not well controlled, and very poorly controlled. Treatment response and medication requirement as being easy to control, which is well controlled patient with low level of the controller therapy. Difficult to control, not as well controlled patient with multiple and or high level of controller therapies. Exacerbator, despite being controlled, continue to have severe exacerbation, and refractory asthma, which is continue to have poor controlled asthma, despite multiple and high level of controller therapies. This is the reference, and thank you.
Thank you, Dr. Ra, for this nice and comprehensive review of the classification of bronchial asthma. Now the floor is open for our distinguished guest, Dr. Ahmed Sadoun, from the Alabama University to speak about the diagnosis and the treatment of bronchial asthma. Please, Dr. Ammar.
Okay, so welcome everybody. مساء الخير وكل عام والجميع بألف خير. وشكرا جزيلا للدعوة لتقديم هذه المحاضرة اليوم عن علاج الربو القصبي عند الأطفال Bronchial Asthma. and أشكر دكتور رو ودكتور أحمد على التقديم لأنه راح تختصر علي وقت كثير. طبعا ال diagnosis and treatment of asthma in children is a very complex subject. I'll try to share my screen. And it's one of the longest chapters in Nielsen, so it takes usually a long time to go over the diagnosis and treatment. So I'll do my best to go over those things in the shortest time possible. So I work as a pediatric pulmonologist at the Children's of Alabama in the US, and also at the University of Alabama at Birmingham. I receive royalties from Up to Date because I'm one of the authors, but I don't have any conflicts related to this presentation. Some of the interventions that I will mention, they are research-based, and they may not be part of the guidelines, just for everyone to know. If you have any question related to this presentation, please leave the question in the chat box below. So when I finish the presentation, I'll try to answer as much questions as possible if we have time, because we may not have enough time. And I thank Dr. Layth Al-Harbawi for putting his comment in the chat box, so everyone can use that chat box. Those are the objects for my presentation today. So I'll try to talk about how do you suspect pediatric asthma, which has already been covered, so I'll go over that really fast. And then I will talk about how to confirm the asthma diagnosis if you are suspecting asthma. What is the differential diagnosis of asthma in children? How do you treat the asthma in the outpatient setting, so in the clinic, and then how to treat asthma exacerbation when the patient is admitted to the hospital. And finally, and we should always talk about COVID-19 and its relation to the pediatric asthma, just if anybody has a question. So let's start. And as I said, I will probably go a little bit fast. I apologize for that, but just for the sake of time. So you have to go back to your families during Eid. So the diagnosis of asthma, as I mentioned already, so I have this prolonged cough, wheezing, seasonality, and they have usually special symptom pattern, as was mentioned by Dr. Ahmed and Dr. Ra. And then you should always ask about specific triggering factors for each patient. So every patient have special triggering factors that can trigger their asthma. And this is important to know. So when you advise them about how to avoid those triggering factors, you know what kind of questions to expect and what are the evidence-based facts you need to tell the patients. And those are the common triggering factors. Usually upper respiratory tract infections are the most common cause of asthma exacerbations in children. But some children have exercise, weather change. Secondhand smoking is very important, predisposing factor for asthma and also triggering factor for asthma exacerbations and asthma symptoms, allergens, irritants, and stress. To complete the history, there are very important parts of history that you need to cover also for every patient with asthma, especially during the first visit when you first suspect asthma diagnosis. So family history of asthma and allergies, especially atopies, is very important. Environmental exposures, past medical history, medications that the patient is using now and that has used in the past can give you a hint about the diagnosis of asthma. Any admissions, ED visits, and specialty clinics visits, school absentees because of asthma symptoms, physical education, which is the exercise at school, and social history. So how many people in the house, where do they live, anybody smoking in the house, if there are any pets at home, those are very important factors. And then physical exam, as was mentioned, those are the important things to look for. They usually happen in patients who have moderate to severe asthma, not as much in mild asthma or episodic asthma. So decreased air exchange with wheezing, prolonged expiratory phase, dry cough in the clinic, comorbid conditions such as allergic rhinitis, conjunctivitis, halitosis, which can be a sign of chronic sinusitis. This is commonly associated with asthma. Eczema is one of the significant associated comorbidities with asthma. Nasal polyps can happen in special subtypes of asthma, especially those with aspirin allergy, and also in other conditions that can mimic asthma, such as cystic fibrosis. Chronic uncontrolled asthma can lead to increased AP diameter of the chest, and obesity can increase the risk of having asthma and can make it more difficult to control the asthma. So it's very important to tackle obesity at the same time as you treat asthma. This is Children's of Alabama, where I work. It's a new building that we moved in 2012, and it has two buildings connected together with this bridge here. And it's 12 floors, and we live on the 10th floor, the pulmonary department. We treat asthma patients up here. So now you're suspecting the diagnosis of asthma. How do you confirm the diagnosis? And as Dr. Roa mentioned, we usually follow the NAEPP guidelines that are released frequently and updated as the new information arrives. And their recommendation is to use spirometry, which is a part of lung function, as a first step to diagnose asthma. Because with spirometry, you can first diagnose asthma and confirm the diagnosis. And second, you can also categorize the asthma into the different degrees of severity, as was mentioned earlier as well. So those are the three most commonly markers that we look at when we interpret spirometry results. The first one is FEV1, less than 80%. And the lower the FEV1, the more the risk that the patient have exacerbations in the future. The second marker is the FEV1, which is the forced expiratory volume at per second, over the FVC, which is the forced vital capacity. If it's less than 85%, this is consistent with the diagnosis of asthma. And the lower the ratio, the more impairment the patient has. So less exercise tolerance, less sleep quality, worse symptoms during the day, in between the episodes. The third marker that we look at is the mid-flow, we call it, which is forced expiratory flow between 25 and 75%. And if it's less than 65%, this is again is a confirmatory diagnosis of asthma. And this is a very sensitive parameter. So even patients with asthma with normal FEV1 and FEV1 over FVC, they can have low mid-flow. And this is usually true in patients who are athletic. So patients who are like football player or they're very active with track runners, they can have even high normal FEV1, even when they have significant asthma, just because of the exercise. But they usually have lower FEV of 25, 75. Most of the times, if patients have normal values, but they have typical history of asthma, we use reversibility tests. So we do a baseline lung function, and then we give the patient a B-roll, usually in the form of inhaler, 4 puffs typically. What we use 4 to 6 puffs for younger patients and 6 to 8 for older patients. Repeat the spirometry. If the FEV1 goes up by more than 8% in young children, then this is a confirmatory diagnosis of asthma, even if the baseline numbers were within normal limits. In adults, they use 12% difference to diagnose asthma. And just to be clear, when I talk about children in regard to asthma, I'm talking about children who are less than 12 years of age. Children who are more than 12 years of age, they're treated and diagnosed just like adults. So this, when we do this test and you have those results, you can kind of confirm the diagnosis of asthma in that specific child. And then, as Dr. Aura mentioned, then it will help you categorize them to mild, moderate, and severe persistent asthma based on the FEV1 and FEV1 over FVC values. So FEV1 less than 6% and ratio less than 75% is consistent with severe asthma when you do it as baseline in between the exacerbations. And this is the classification of the NA-EPP that they went over a while ago, and in terms of impairment and risk for asthma exacerbation. So I will not repeat that again. So this is the first step of diagnosis, is to use the spirometry. The issue with the spirometry that we have is it's effort dependent. So the child needs to take a very deep breath and blow to the machine as hard as possible. And the accuracy of the test depends on the coaching. So who's doing the test and how they coach the child into doing the test is what would give us accurate numbers that we can depend on. Unfortunately, for children less than 6 years of age, most of the time they cannot do the test perfectly. So most of the time we cannot depend on the results, but we usually start doing it before the age of 6 to kind of train those kids to use the spirometry the proper way later on in life. But usually after the age of 6, usually after 2-3 times, they start to do it right way. We can depend on the numbers, which can be very helpful to follow the response to treatment and manage their asthma. So it is effort dependent, cannot be used in young children. So we're trying to find other kind of solutions to measure lung function in younger kids. And one of the other modes of diagnosis is impulse oximetry. So this is non-effort dependent, and you just put the machine on the mouth of the child, and the machine will measure the lung function on its own. And during this presentation, I'll try to present some of the research work that we have done over the last 15 years or so on asthma. Although asthma is not my primary research specialty, my research usually focuses on factors that affect lung development, sickle cell lung disease, and cystic fibrosis. But I have done some research about asthma that I will show you some of the results. So one of the papers that we published about the use of impulse oscillometry is this paper that was published this year in Nature, as you see here, which is the highest ranking journal in the world. And we use this impulse oscillometry machine to measure lung function in very small babies, like 1 to 3 days of life. So if you can measure lung function in small babies, then you can measure lung function in older children. So the machine looks like this, and older children use the mouthpiece. So the child seals the mouth around this one, and then hold their cheeks, because what this machine does, it sends some ultrasonic waves into the lungs, and then the waves that come back will tell you how much resistance and compliance the lung has. So you just seal your mouth around it. You don't just breathe normally, clip the nose, and then the machine will do the measurements. For a smaller kids who cannot seal their mouth around it, we usually put a mask and then cover the mouth and nose with the mask, and this will give us the lung functions. And this is the result from this paper that I showed you. And we measured 2 measurements. So here on the x-axis, this is the frequency. So we measured the reactance on the y-axis and the resistance, both of those at different frequencies and at different ages of life. So this is at day 1 of life. We controlled we compared the controls, so normal babies with no issues with the breathing, in those dark circles and triangles. We compare them to babies with a transient tachypnea of newborns. Those are the open circles and open triangles. And we found that patients with TTN They have higher resistance, especially at lower frequencies. But the most significant thing, that have lower reactance, which means less lung compliance and more stiffness of the lungs, which we know that happens. But just to confirm that we can do this test and can differentiate the lung pathologies. So we are now doing more research on different lung diseases in small babies using this machine, the impulse oscillometry. Other tests that we can use to confirm and follow patients with asthma is the peak expiratory flow rate. And this is used mainly to monitor the response of patients to asthma treatment and to measure their long-term symptoms with time. So we give the machine to the patients at home, and they record the numbers. That they have a diary. So they record they blow into the machine, they record the number in the morning and evening every day. And when they come back to the clinic, they bring this diary with them. And by looking at the diary, you can tell if their asthma is under good control or not, and when is the worst symptom they have, what day and what time of the day. And so it is helpful, but it needs a lot of cooperation from the patient side. So a lot of families, they cannot keep on with those diaries every day. So we just use them in very selective patients. The other test that we use here in our clinic is the exhaled nitric oxide. So the machine will, the patient will blow into the machine, and the machine will measure how much nitric oxide gas is in the exhaled air. And the higher the nitric oxide level in the exhaled air, the more the chance that the patient has eosinophilic asthma. And as you know, the asthma can be categorized into eosinophilic and neutrophilic asthma. Patients with the eosinophilic asthma, so they have a lot of eosinophils, eosinophilic inflammation in the airways, they usually respond very well to inhaled corticosteroids, because corticosteroids, they direct their action against eosinophils. They cause apoptosis of the eosinophils. So when you give inhaled or systemic steroids, the eosinophils will just disappear from the airways. So if exhaled nitric oxide is high, then this means that the child has eosinophilic asthma and that they respond to inhaled steroids. And this is the cut line that we use. So more than 20 parts per billion in children and more than 25 parts per billion for adults or children more than 12 years is used as a cut line for diagnosis of asthma with eosinophilic inflammation in children. The next test that we sometimes use is the allergy test. And this is used in patients who have symptoms of worsening asthma, cough, when they're exposed to specific allergens. So we confirm this with those tests. So we can use either the skin prick test, you use it usually in the back or in the arms of the child. We prick the back with different aero and food allergens that we're aware about in our environment. We have a positive control, which is the histamine, and negative control, which is the preservative that's used for the allergens. So if one of the allergens has significant reaction that's close, usually more than 3 millimeters in duration, close to the histamine, then we can say that this child has allergy to that specific allergen. Skin prick test is very sensitive, meaning that it can detect allergies that may not have clinical significance. So we have a lot of cases that they will be allergic to 3 or 4 food allergens, but they eat that food without any symptoms, just because the test is very sensitive. On the other side, the specific IgE, so those are IgEs that are specifically targeting special antigens. We do a blood test, and we have a long list of allergens that specific IgE are increased in level in this blood. This test is specific, so if the test is positive, then this means that the child is allergic to that specific allergens. And there's usually 0 to 5 in terms of the level of IgE. 4 to 5 is significant for allergies. Lower than that is not significant. The other test is a bronchoprovocation test. So we use this test in patients who have typical asthma episodes, especially those who have episodic asthma. So they do very well between the episodes. They don't have any symptoms whatsoever, but then as soon as they're exposed to any triggering factor, they have severe asthma attacks. Some of them are very severe that they need to go to the ICU. So for those patients, we use a triggering test just to confirm the diagnosis of asthma to make sure it's not something else. Because some patients with anaphylaxis, for example, they can present like asthma. So we use the methacholine challenge test, cold air or exercise, depends on what trigger caused severe asthma episode. And apparently this test needs to be done in specialized center and you have to have resuscitation around. So we don't do it frequently, but when we need to do it, it's very useful. Chest X-ray is done if patients have suspicion of other diagnoses other than asthma. So you're suspecting some chronic suppurative lung disease, CF, congenital lung disease, or other diagnoses, especially when they have poor response to asthma. We usually use it for patients who have severe asthma. When they first come to our clinic, to the specialty clinic, we do a baseline chest X-ray to rule out other diagnoses. Sodium chloride, apparently do it in patients with atypical symptoms of asthma and more kind of have symptoms of cystic fibrosis. So patients with fail to thrive, recurrent pneumonia, malabsorption, or other symptoms of CF, you need to do sodium chloride. Barium swallow, if you are suspecting aspiration, especially in very young children with chronic wet cough, choking and coughing whenever they drink or eat anything, then you do barium swallow. This is a publication about the exhaled nitric oxide in our area. We did it like 12 years ago, and this is the machine that we use for the exhaled nitric oxide. So you take a deep breath and then blow into the machine with a certain flow rate, is 50 ml per hour per minute, plus minus 5. And this screen will help you determine the flow that you need to blow. So if you blow for 6 seconds within this flow, then you'll have the exhaled nitric oxide level. And we found that this is our publication in the maroon, and those are all of the other publications about the baseline level of exhaled nitric oxide. And we found that exhaled nitric oxide is higher in younger children in our study, but they will go down in older people. And we found that in our population, the level is higher in males. So this dotted line is the male. The pink is the female. So in males, they have peak of exhaled nitric oxide around the age of puberty, most likely due to hormonal changes. This is the University of Alabama at Birmingham, where I work. This is Children's of Alabama up here on the left, and this is other colleges. They are all connected together with the bridges, so you can go indoor all the time, all through the buildings. So now we have a diagnosis of asthma, but what could it be else? What if it's not asthma? The patient has chronic cough, that's not asthma. This is especially true in patients who don't respond to asthma treatment. Then you need to think about other diagnoses. And each one of those diagnoses needs a complete lecture on its own, but the most common one seen in younger children is protracted bacterial bronchitis. So this follows a viral infection. The patient will continue to have wet cough, not much fever. Chest X-ray is normal because the infection is inside the bronchi. So it's chronic endobronchitis. Just because of poor blood supply to the bronchi, the infection is hard to be cleared up. So treatment is usually with prolonged course of antibiotic, usually 2 to 3 weeks. And we usually do flexible bronchoscopy to know what kind of bacteria is there and what kind of antibiotic needs to treat that specific bacteria. Chronic suppurative lung disease, such as bronchiectasis or recurrent pneumonia with lung abscess or emphysema, kind of present with chronic cough as well. Diagnosed usually with chest X-ray and CT. Airway anomalies, especially airway malacia, which is a flappiness of the airway, which is more common in premature babies. And also airway stenosis, which is also common in premature, especially after prolonged intubation and vent. Aspiration, we talked about that. Do the patient is aspirating either because of CNS issues, they have developmental delay, or because of anatomical issues, such as laryngeal cleft, TE fistula, or other kind of anomalies that dispose them, vocal cord paralysis. All of those patients can have aspiration to the lungs, and they have this chronic wet cough that resembles asthma but does not respond to asthma treatment. Chronic and less common infections such as tuberculosis, NTM, and non-tuberculous mycoplasma, whooping cough, and other chronic infections, they can have chronic cough that's not responsive to asthma. Interstitial lung disease is very rare in children. We see it sometimes in association with rheumatologic diseases, but other than that, it's rare. Cardiac causes can present as asthma, especially heart failure, but usually they have other symptoms such as sweating with feeding, tachycardia, sometimes cyanosis in the advanced stages, fail to thrive, and large heart on the chest X-ray. Upper airway cough syndrome, this is because of post-nasal drainage because of allergic rhinitis or post-viral infection or sinusitis. So the children will have cough mainly at night because the secretions will drop into the back of the throat and they will continue to cough at night. And the last one is vocal cord dysfunction. This is a very common mimicker of asthma, especially in teenagers, more common in females, athletics patients, and they can present like exercise-induced asthma exactly. So as soon as they start exercise, they will start have shortness of breath and cough, and they'll have stridor, which can mimic wheezing. So when you ask them if they have wheezing, they will say, yeah, we have a sound when we breathe in and out. But the differentiated thing with vocal function is problems happen when you inspire, when you inhale air in, not when you exhale. So in the history, it has some hints. The symptoms start as soon as you start exercise, while in asthma, it usually starts after like a few minutes after starting exercise or after the end of exercise. And this is one of the case reports that we published a few years ago about a patient who was 7.5 years old who has asthma, but presented with symptoms typical of vocal cord dysfunction. So what I did is I scoped him during one of those exacerbations. And normally when you inhale, you open your vocal cords. When you exhale, you close your vocal cords. That's how we speak, right? But with vocal cord dysfunction, when they breathe hard and fast with exercise, the vocal cords will close down when they inhale in. So that's why they have difficulty getting air in, and they have this stridor sound with breathing. So when I scoped this child, this is the left picture was when he was inspirating. So his vocal cords was closing. When he was exhaling, they were opening up. So this means that vocal cord dysfunction can mimic asthma, and also it means that asthma can happen with vocal cord dysfunction. This is another patient that I saw on July 23rd, so 10 days ago. He's a teenager, 14-year-old, who was followed by one of my colleagues for asthma. But despite the asthma treatment, this is his lung function. As you can see, since 2017 here on the left until 2020, there was a decline in his lung function with time, despite the asthma treatment. So this was very concerning for my colleague. So she ended up referring him to me just to see what's going on. So let me just take this out of our way, and I'll go back to the presentation. So this is his lung function. This is how we report lung function normally. So this is FVC1, FEV1, FEV1 or FVC, and those are the percent predicted for that specific patient compared to patients of his age, height, gender, and race. So as you can see, we talked about the values. So FEV1 is 90%, FEV1 over FVC is 89%, mid-flow is 78%. So all of those are within normal limits. So by definition, he does not have clear evidence of asthma. But if you look at the curve here, so this is the flow volume curve. This is when you inhale in, and this is when you exhale. Normally, when you inspire, the curve should be round. So should go, sorry for that, should go down to here and then up. And when you exhale, you should have this peak. And normally the value should fall within this shaded area here for that specific patient. So as you can see here, there is a flattening of the inspiratory curve here. There is poor peak, so the peak didn't go all the way up here. And then there is flattening of the expiratory curve as well. So this is a typical lung function of vocal cord dysfunction. So this patient, I diagnosed him with vocal cord dysfunction, and I consulted the speech therapy to do the intervention needed to treat this. So most of the patients, after 1 to 2 sessions of speech therapy intervention, their lung function will come back to normal. Treatment of asthma. So I try to go fast over the next 10 minutes over treatment of asthma. So we need to agree with the parents about what are our goals to treat the asthma. Why do you want to treat asthma? So those are our goals that we need to make it clear when we talk to the parents. So we need to prevent or decrease the chance of asthma attacks because those can cause death. We need to try our best to have the patient symptom-free, so no cough, no shortness of breath, improve sleep quality, because if the patient coughs all through the night, they will not have good sleep at night, and they will have difficulty the following day. And they will be irritable, agitated, poor focus. To optimize the lung function, bring it back to normal, to have normal daily activities so they'll be as active as possible without having symptoms, to reduce the need for salbutamol, because the more you use it, you'll have internalization of beta-2 receptors and it will be less effective when you really need it. So we try our best to decrease the use of salbutamol as much as possible. And finally, you need to have the patient and family satisfaction, so they'll be happy about how their child does. The mainstay of chronic outpatient asthma treatment is the inhaled steroids, because they treat the pathophysiology of asthma, which is the inflammation. And they improve the impairment, so they decrease the symptoms significantly, and they improve the activity tolerance of the patients. They also reduce the risk, so they decrease the need for systemic steroids, which will be associated with side effects. They can prevent the irreversible decline in lung function with time, especially during the active lung growth of the children. And they can prevent or decrease the chance of asthma exacerbation. The parents need to know that the inhaled steroid will have a gradual onset of action, and usually the full effect will show after 4 to 12 weeks. So they need to be patient, waiting for the effect of inhaled steroids. Of course, they can be associated with adverse effects. So there are local and systemic adverse effects that can happen with inhaled steroids, including those listed here: dysphonia, thrush, high sensitivity, irritation. Systemic adverse effect usually happens with very high doses for a long time. It's very rare, but the two most common adverse effects are adrenal suppression and a growth deceleration, which is only 1.1 centimeter of the adult height. So it's not much. And this was driven from the CAMP study, which is one of the biggest randomized controlled trials of inhaled steroids in children. And they compared the final height of children who used steroids to those to their siblings who are not on steroids. To minimize the adverse effects, we need to use the lowest dose of steroids possible, as much as possible. So we see those patients every 3 months in the clinic to see if we need to step up or step down their treatments. And if there is any way to go down on the dose of steroids, we do that. Second thing, we need to use a spacer always with inhalers. So we use the metered dose inhalers, MDIs, with the spacer to decrease the local and systemic adverse effects. We need always to treat comorbid conditions that we mentioned: allergic rhinitis, sinusitis, and reflux disease, because this can make the control of asthma much more difficult if they're still there. To maximize the non-pharmacological treatments, which includes the trigger avoidance. The other modality of treatment is the leukotriene antagonist, such as Montelukast, the most commonly used. It's given by mouth once a day. They're less effective than inhaled steroids, but usually we add them to inhaled steroids if the inhaled steroids are not enough. The more effective treatment is the long-acting beta-2 agonist, or LABA. Those are also used as an adjunct therapy on top of inhaled corticosteroids, and they improve the action of inhaled corticosteroids. We don't recommend using them as monotherapy because they don't treat the cause of the asthma, which is the inflammation. They just open the airways. The most commonly used are the salmeterol, which is the onset is more than 30 minutes, and the formoterol, which starts its action after 3 minutes, similar to the salmeterol. The formoterol is used as rescue inhaler, just like salbutamol as well. The other treatment is the LAMA, we call it, a long-acting anticholinergic agent. The most commonly used is the tiotropium. It's bronchodilator, and it's used when the patient is on inhaled corticosteroids and long-acting beta-2 agonist, but they're still not well controlled. So we add the LAMA. The most commonly used here is called Spiriva. It lowers the risk of exacerbations and improves the lung function in patients who are already on combination therapy. And the last step usually in the standard treatment is the biologics. So patients with high IgE level, we use omalizumab, especially those who have perineal symptoms. So they have symptoms all through the year. It's very effective. And those who have severe asthma that's not well controlled. The next agent is the mepolizumab, which is used for patients who have high eosinophils. So it's the refractory eosinophilic asthma. Both of them are given by injections. The first couple of doses are given in the clinic because of the risk of anaphylaxis. The following doses can be given at home if the parents feel comfortable about giving the medications. And they have different dosing regimen. Less frequently used medications to treat chronic asthma is systemic steroids. We use this very occasionally in very severe asthma patients. But as you all know, with the severe side effects of steroids, we try to avoid them and to minimize the adverse effects, we use the lowest dose possible. I always switch them to every other day dosing as soon as I can. Maximize other therapy and use trigger avoidance as much as possible and allergy shots. Chromoglycase, we don't use them as much now, the cromolyn and nidocromol. They are mast cell stabilizers. They're much less effective than inhaled steroids, so we don't usually use them in moderate and severe persistent asthma. And they're not much available in the market here. Theophylline, it's a bronchodilator and anti-inflammatory. It has serious adverse effects, including short-term and long-term adverse effects. Short-term include cardiac arrhythmias, seizures, and death, and long-term adverse effects, including learning and behavioral disorders, which are very significant. You need to measure, to monitor the drug level and keep it within narrow window, 5 to 15 microgram per ml. Otherwise, it will be either ineffective or it will have adverse effects. So we don't use this as well. This is the guideline of the NA-EPP that we use in the clinic. So for intermittent asthma, we use SABA here. And then for the persistent, we use step 2 to 6. So if the patient is at step 3 or 4, they need to go special clinic here. You need always to educate the patients, try to control the environment and manage their comorbidities. Whenever you step up the treatment, you need to check if they're using the medication, if they use a proper technique, if you control their environmental exposures, if you are treating their comorbid condition. And if their symptoms are improved over 3 months, then you try to step down the treatment as much as possible. So you go to the next step. So step 1 for intermittent asthma, you use salbutamol as needed only. Step 2 for mild persistent asthma, you use low dose inhaled steroids. If there is no response after 3 months, you go to either add LABA or use Montelukast or theophylline as an add-on therapy to the inhaled steroid. If there is no response, you increase the dose of steroids. So you use medium dose inhaled steroids with long-acting beta-2 agonist. And this is the preferred option. With step 5, there is still no response. The patient has persistent symptoms, recurrent exacerbations. Then you use high dose inhaled steroids with LABA. And of course, for every step, there are alternatives. If the patient has any issues with any of those, you can go to the alternatives here. And for the most severe ones, you start biologics and oral systemic steroids for those patients. And of course, at this level, they need to be followed in specialist clinic. So patient education is very, very important, because if the parents, they don't recognize the importance of controlling asthma and how to use the medication the proper way, then it will be useless. This is what we use when the patient comes to the clinic. They fill this form on an iPad. And this is the asthma control test to see how controlled their asthma is. And then we get the final score down here. If it's 19 and above, the asthma is well controlled. Less than 19 is uncontrolled asthma. And this is a booklet that we give to all of the patients during their first visit. It includes information about asthma, basics, medications, spacers, asthma action plan, triggers, well-controlled asthma, and glossary. So every new patient, they will have this booklet that they will read when they go home. We also give every patient, every visit, this asthma action plan, which are 3 zones, just like traffic lights. So green zone, they're well controlled, what the patient needs to do. We type here all of the medications that the patient needs to use every day. What happens if the patient starts to have mild exacerbation? We write here what they need to do, how to call. And then what happens with the red zone? They have severe exacerbations, what they need to do, what to call. So this would be available at home at hand in case they have symptoms. On the back of this asthma action plan, we circle what medication the patient is taking currently. So those are the medications that we are currently using, both the controller and the quick rescue, and also the types of the air chamber. So we circle the ones that the patient use just to avoid any confusion. So for the non-pharmacological treatment, we need either to avoid the triggers if possible, of this allergen or smoking or irritants, or we can try to adjust the treatments if the avoidance is not possible, like exercise, cold, hormonal fluctuation, or extreme emotions. This is pictures from our celebration with Eid yesterday, just for you to see. So we had some celebration here, but we stayed in the car. We got some goodies and gifts and candies. For asthma exacerbation, which we try our best to prevent, it can either be mild, which sometimes manage at home, but sometimes need to go to the ED. Moderate asthma exacerbation, they need to come to the ED for sure. Severe asthma exacerbations, they usually need to be admitted to the hospital. And those are the symptoms for severe asthma. Patients will be very sick, including hypoxia. Treatment of asthma exacerbation is oxygen if needed. So if oxygen saturation is less than 92%, they need to be put on oxygen. Bronchodilator, so salbutamol is the mainstay of treatment. We usually use the racemic salbutamol. We use nebulized most of the time because we need to give oxygen with it. And also sometimes we need to give ipratropium bromide, which can be given by nebulization. And in mild exacerbation, we use intermittent, but in severe, we use continuous. We usually mix the salbutamol with ipratropium bromide, which is the Atrovent. We give usually 3 doses. Initially, if the patient responds to those 3 doses and symptoms improve, we send patient home with steroids. If they don't improve, we admit them to the hospital. And they found in this meta-analysis, collaborating all of the randomized controlled trials, that adding ipratropium bromide to SABA will decrease the chance of admission to the hospital by about 27%. So it's very useful. Other bronchodilators that we use if there is no response to the salbutamol and Atrovent is magnesium sulfate. We give it usually IV, 50 mg per kg. And then the next step is to give parenteral beta-2 agonist. So in emergency condition, we give subcutaneous or intramuscular epinephrine or terbutaline, especially if a patient has severe asthma episode while obtaining an IV access to give it IV. As soon as we get IV, we start IV terbutaline. We send the patient to the ICU. The mainstay of asthma exacerbation treatment is systemic steroids. So all patients with asthma exacerbation, they need to be on steroids, especially those with moderate and severe asthma. We usually give 3 to 5 days of prednisone or prednisolone based on the age of the patient. We usually prefer PO, so by mouth, instead of IV, because they both have the same bioavailability. So the patient can take PO, we give it PO. If the patient is so sick or intubated, we give it IV. And giving systemic steroids will help decrease the chance of admission to the hospital and recurrence of asthma by 50%, as in this meta-analysis. Other unusual treatments is helium. We use it sometimes with severe asthma because it has lower gas density, so it can penetrate into the even very narrow airways. Ketamine, which is dissociative anesthesia agent, we use it if the patient needs intubation and ventilation in the ICU because it's a bronchodilator as well. And IV montelukast or leukotriene antagonist, we use it only in limited patients who prove to respond to oral montelukast. When the patient needs admission to the hospital, we put the patient on something called asthma clinical pathway. And those patients are evaluated every 2 hours by a respiratory therapist for those factors here on the left. So they are evaluated for wheezing and air exchange, excessive use, dyspnea, and respiratory rates. And based on those factors, they be categorized either at good, fair, or poor. And then they will add all of those scores, and you'll have a score of 0 to 8. And based on the score, you can decide if this patient needs to go to the ICU, special care unit, or regular floor. And then as soon as the patient go to the floor, they will go on this pathway. It's a little bit complicated, but all of the respiratory therapists, nurses, and physicians are aware about it. And it has 4 phases. So phase 1 is very severe asthma. Those patients usually go to the ICU. Phase 4, when they improve and they're ready to go home. So every 2 hours, they're evaluated, and the treatment is changed accordingly, and they move through the phases until they reach phase 4. If they're on phase 4 for 4 hours, then they can be discharged home. So it's managed by respiratory therapists in the hospital. And since we studied this asthma clinical pathway, our duration of stay and outcomes of asthma improved significantly because the patients are checked on every 2 hours, and if they're sicker, we'll aggravate the treatment. If they're better, we'll send them home soon. Now the final slide is about COVID-19. So Fortunately, children are not affected as much as adults with COVID-19, as you all know. And so far, we think that pediatric asthma is not a strong risk factor for COVID-19. However, we need to ensure that asthma is well controlled, because this will decrease the chance of having severe COVID-19. And also this will decrease the chance of child needing to go to the hospital and exposed to COVID-19 in the hospital. So the better the asthma is controlled, the less the chance of having COVID-19. So we continue all of the controls, including biologics. We advise all of the patients to stay indoor and to stick to the preventive measures, so social distancing and mask as soon as they go outside. And in the hospital, we changed the asthma clinical pathway since COVID-19. We switched all of the salbutamol to inhaled instead of nebulized in order to reduce the spread of infection to the rest of the hospital. This is the end for my presentations, and Eid Mubarak again, and I'm ready to take any questions, and I apologize for the prolonged talk, which is kind of expected on my side. I'm sorry for that.
Thank you very much, Dr. Amar, for this very comprehensive and updated review about the diagnosis and treatment of bronchial asthma, and you updated us about the most recent update. Now I will open the floor for discussion and question, and please use the raise hand facility for question. In addition, I think Dr. Amar, you have a few questions in the chat. If you can answer them, please.
Yes, so I see the first question is, what do you think about the use of magnesium sulfate or MAGD? And I already answered this question. So there are a couple of sides to that. One is, if the patient has received the 3 doses of SABA and the ipratropium with the atrovent, and they're still struggling to breathe, we usually go ahead and do magnesium sulfate. As I said, we use 50 milligram per kg, and we use a maximum of 3 doses, 6 hours apart, and we usually follow the magnesium level in the blood for those patients. There is a randomized controlled study about using MAG sulfate on all of the patients who come to the ED with asthma exacerbation, and they found about 20% reduction in the risk of free visit to the ED and readmission if you give like 1 dose of MAG sulfate. It's not the standard of care, but it's just one of the randomized trial that was given. It's pretty safe medication, but can have a risk in patients who have underlying lung disease, kidney disease. So the patient have renal issues, you need to be very cautious. We usually do it under monitor. So the patient need to be monitored at least 1 hour after we finish the MAG sulfate to be sure that they will not have bradycardia and hypotension, because some of those patients, they can have a hypotension with MAG sulfate because it's a vasodilator in addition to a bronchodilator. It is pretty effective and safe for the patient that we use, but as I said, we use it maximum of 3 doses, and we monitor the magnesium level in the blood.
Okay.
Other questions?
Can we have a question and then we go back to the chat, Dr.
Yeah,
Amar?
sure.
Ibrahim? Unmute yourself, please, Ibrahim, and speak your question.
السلام عليكم.
وعليكم السلام ورحمة الله.
دلاني السرير إبراهيم إسماعيل دائرة صحة نينوى. طبعا شكرا جزيلا دكاترتنا، شكرا جزيلا دكتور عمار على المحاضرة القيمة والمعلومات. بس عندنا يعني مشكلة الآن، احنا بالنسبة للأسمة احنا ندري انه النون ستيرويدال هي كونترا انديكيت، بس بعض الحالات اللي تجي يعني احنا ما نقدر نوفر البين كيلر، يعني ما دائما متوفره البين كيلر الحالات الاسمه، فهل نستطيع انه نستخدم احنا النون ستيرويدال يعني في بعض الحالات للاسمه؟
شكرا جزيلا. طبعا هذا سؤال مهم جدا ودائما يسالون اياه مرضى الازمه اللي عندنا. اذا المريض عنده فايرال انفكشن وعنده حراره، عاده احنا نبدي بالباراسيتامول. لأنه paracetamol is is anti-inflammatory, is antipyretic. It can be used to relieve the pain and fever and does not have any bronchoconstriction effect. فنحن نبدأ عادة بالباراسيتامول لأنه ما له تأثير على الأزمة. إذا المريض ما استجاب للباراسيتامول بعدين نروح للنون ستيرويدال. بالنسبة للنون ستيرويدال مو كل البيشنت with asthma ما يقدرون يستخدمون النون ستيرويدال. بالنسبة لعندنا بالمستشفى إذا مريض عنده mild asthma أزمة بسيطة عادة ممكن يستخدم نون ستيرويدال بالبيت، نقول لهم إنه ممكن يستخدم وماكو أي مشكلة. المرضى اللي عندهم moderate and severe asthma، خاصة severe asthma، نسوي لهم تيست بالعيادة لما يجون عندنا بالعيادة، نعطيهم 1 dose of the non-steroidal مثلا ايبوبروفين بالعيادة. إذا صغار أقل من 6 سنين نعطيهم الدوز ونراقبهم لمدة 4 ساعات بالعيادة. إذا ما صار عندهم أي symptoms نقول لهم ممكن يستخدمون ال lowest dose possible. Usually نعطيهم less than the regular dose. So usually it's 10 mg per kg. We usually use 5 milligram per kg of ibuprofen, for example. If the patient older than 6 years of age, we use non-steroidal challenge test. نعطيهم a dose of steroid, the regular dose, the 10 milligram, the full dose, ونعمل lung function test before and after the steroid. And we see the difference. إذا ما صار أي effect after 4 hours of taking non-steroid, they can use it at home. بس هذول عادة أقلية جدا، بس المرضى اللي عندهم severe asthma واللي يحتاجون steroid frequently. بس معظم المرضى ممكن يستخدموه. بس اللي لاحظته هنا إنه ما يستعملون الناس كثير non-steroidal anti-inflammatory drugs especially بالأطفال، خاصة مع تأثيراته على الكلية الآن، لأنه خاصة استخدام متكرر للنون-steroidal وجدوا إنه يسوي vasoconstriction بالكدنيز ويعمل tubular damage with the prolonged use. So it can cause chronic kidney failure. فما نحب نستعمل احنا، دائما ننصح المرضى الازمه انه يتجنبون الانتي-ستيرويدال as much as possible. حتى اذا المريض عنده حراره خفيفه ممكن يسوي لكم مهادات وممكن يعطوه باراسيتامول، بس ما يحتاج يعطوه نون-ستيرويدال. But for extreme cases نسوي هاي الاجراءات اللي قلت لك عليها.
Okay, a question from رؤى, one of our top graduate. سؤال حضرتك أو دكتورة رؤى. She asked about at which age we can diagnose a child with asthma.
That is very tricky question. شكرا دكتورة على السؤال. وتحياتي للوالد. طبعا الوالد هو من أطبائنا على فكرة. Very tricky. نحن in the United States general pediatricians and primary care physicians, they cannot diagnose asthma before the age of 2. So قبل السنتين ما يقدرون يشخصون asthma بالنسبة للبيلينج والإنشورنس issues. الوحيدين اللي يقدرون يشخصون asthma قبل السنتين هو السبيشالست. ولهذا أي مريض عنده أعراض asthma قبل السنتين عادة يحولون إياه نسوي له couple of tests. There is infant respiratory function test. ما ذكرت لأنه هو research tool, is not a clinical tool. بس نقدر نسوي lung function test with pre and post for kids up to 2 years of age. Usually we put them in a box and we put a jacket around their chest. We put them to sleep with a chloral hydrate, and then we do lung function at the tidal volume. وبعدين ممكن نعطيهم salbutamol before and after the lung function. فممكن نسوي نفس lung function for the older children, but in younger children less than 2 years of age. So we have many other ways in addition to this impulse spirometry that I just mentioned. Those are other ways that we use to confirm the diagnosis of asthma. If we confirm it, then we can diagnose them with asthma before the age of 2. And I have few patients who are like 6 months of age, and I diagnose them with asthma, treated them, and they did very well. And few of them, they were admitted to the intensive care unit in the first 6 months of age because of severe asthma attacks. So there is asthma predictive score we have, we call it, depends on the eosinophil level in their blood, forced exhaled sputum, and depends on the family history, especially maternal history. So if the mother has asthma or atopy, this is very strong indicator, and this will drive the score very high. So yeah, before the age of 2, it needs to be diagnosed by specialists. After the age of 2, any specialist pediatrician can diagnose asthma here in the US, and they can start treatment for asthma if it's mild. But as we said, if it's step 3 or above, most of the time they refer them to our clinics for further management and diagnoses.
We have a question from دكتور نشوان الحافظ معاون العميد للشؤون العلمية. دكتور نشوان تفضل. Please unmute yourself.
شكرا جزيلا. بالبداية كل عام وانتم بخير دكتور عمار. We are honored to have you with us. Thank you very much for your interesting and distinguished participation and lecture. It is really comprehensive and updating and advanced. We thank you a lot. It was very helpful to us. أنقل لك سلام خاص من السيد العميد المحترم لحضرتك. My question is, what is the specific type of a preferred LABA and inhaled corticosteroid in the age group 0 to 4? The specific LABA, yes.
شكرا جزيلا دكتور نشوان، وشكرا جزيلا على الحضور. طبعا دكتور نشوان كان هو قدوتنا لما كنا مقيمين بالمستشفى الخنساء، كنا دائما نسمع اخباره وتميزه على مستوى البورد، وكنا دائما نتبع خطواته. فانا شرف جدا بكلمتك دكتور نشوان، وسلامي وتحياتي دكتور اسامه، واشكره جدا على هاي الدعوه، وارجو نقل تهنئاتي له على المنصب الجديد دكتور نشوان.
لنا
شرف بحضوركم، شكرا جزيلا. جوابا على السؤال، طبعا العمر اليونج age they're much harder and difficult to treat. Most of the patients who are younger, they're referred to us for treatment. And for your question about was the best LABA and inhaled corticosteroids, so we have different kind of combinations. We have about 5 available combinations of LABA and inhaled corticosteroid that we use. The preferred one for children who are less than 4 years of age is the formoterol. And the reason for that, because it's fast acting and has less cardiac effects than the salmeterol on the long run. So most of the adult study that shows sudden death with monotherapy with LABA were done on salmeterol. So that's why it was a black box. Formoterol, it has less kind of cardiac effects, so it's usually the preferred one. For the inhaled corticosteroid, the most commonly used, the one we use is the fluticasone in younger children. Less than 4 years, if we are using the metered dose inhaler. But if you are using the nebulizer, the only option we have is the budesonide. So budesonide is the only nebulizer available. We use it usually up until 2 years of age, 1 to 2 years of age. As soon as the child's is more than 1 year of age, we usually try our best to switch them to the inhaler instead of the nebulizer therapy. Because as you know, it has better delivery to the lower airways than the nebulization therapy. It has less adverse effects, and it takes much less time and effort on the family side. Especially if there is no electricity, you cannot give the nebulizer, but the inhaler is more kind of portable. So you can take it wherever you go, and you can give it at any time. And it just takes a couple of minutes to give the inhaled steroids. So usually we try our best to switch our patients to inhaled steroids when they turn 1, but most of them, they will be on inhaled steroids when they turn 2. And during this time, we use budesonide. After the age of 2, if they are on inhaled steroids alone, we use fluticasone. If they're on combination therapy, we usually use something called Symbicort here. I don't know if you have it. It's a combination of budesonide and formoterol. So it will give you the best kind of combination therapy for kids who are less than 4 years of age. And we typically use it 2 puffs in the morning and 2 puffs in the evening. And some of the selected family, we use the Symbicort, which is the formoterol and the fluticasone. We use it as a rescue therapy as well. So if we find that some of the families, they have confusion between the salbutamol and the control therapy, they don't know which is which. And we have this a lot in the clinic. They will come to the clinic, they will tell you, we're using salbutamol 2 puffs in the morning, 2 puffs in the evening, and the combination therapy as needed, which is the opposite. So in those families, sometimes I switch them just to monotherapy, which is the Symbicort, which is the combination of budesonide and formoterol, because they can use the same inhaler as controller and as a rescue inhaler. So when they develop acute asthma exacerbation, I ask them to use 4 puffs of the combination therapy every 4 hours during asthma exacerbation. And if they need that for more than 48 hours, for more than 2 days, then they will go into the red zone, we call it. In the asthma action plan, they need to be started on systemic steroids. But if the child gets better over the first 2 days of using this kind of regimen, then we'll go back to just 2 puffs in the morning, 2 puffs in the evening. So this can make sometimes things easier for the families. The 2 problems that we have to this plan here in the US, one is some of the insurance companies that don't cover this plan. And the reason for that, which is the second problem that we have, is the combination therapy is much more expensive than the salbutamol. So if they have to use it as a rescue and as a controller, this will increase the risk of course, especially patients who have frequent exacerbations. So all of those things are things that we usually consider in the clinic when we decide what kind of control for kids less than 4 years of age. But yeah, I agree that this is usually the most difficult age to diagnose and to control their asthma. And the other thing that they have a lot of comorbidities, and they can't have any of the differential diagnoses that we mentioned. Usually it is much harder to rule out other diagnoses in younger children than older children, because with older kids you can do lung function and you can confirm the diagnosis, but with younger kids it's much difficult to rule out other differential diagnoses. But thanks for the question. This is a very good question.
Thank you very much.
Okay. We have احمد الشلاش. تفضل احمد. Unmute yourself please.
السلام عليكم. أحمد إسماعيل، طالب طب نينوى مرحلة سادسة. شكرا لأساتذتنا دكتور أحمد دكتورة رؤى، كذلك شكرا للدكتور عمار أحمد سعدون على هالشرح الرائع وللجميل. سؤالي الدكتور عمار، الجولد ستاندرد انفستيجيشن للدايجنوسيس مع الأسمة، يعني اي دايجنوسيس اي انفستيجيشن نسويه حتى يعني نتاكد انه هذا 100% عنده اسمه. وشكرا.
شكرا جزيلا احمد على هذا السؤال. وطبعا كما ذكرت بالمحاضره، عاده معظم الدايجنوسيس I would say for my patient more than 80% of the diagnosis depends on the history and exam. When you suspect asthma, most of the time it will be asthma. So you don't have to do a lot of investigation. بس مثل ما ذكرت بالمحاضرة, the gold standard for diagnosis of asthma is the spirometry, which is a lung function test for patients who are 6 years and older. Patients less than 6 years of age, especially those between 5 and 6, you can try to do a spirometry, but you may not be able to do it, as I mentioned when I talked about spirometry. But for patients more than 6 years of age, we usually in our clinic, we don't confirm the diagnosis of asthma without doing a lung function test, because this way, as I said, you can confirm the diagnosis by having an obstructive lung disease. You can confirm the reversibility of obstructive lung disease, which is the main point for diagnosing asthma. And you can also assess the severity of the asthma, so you can decide what kind of treatment you need to start this patient on. The problem with the spirometry that it may not be available in all of the clinics. In the US here, now it's available in most of the pediatrician clinics. And the reason for that, because it's more affordable now. So there is a machine that you can buy and it's FDA approved, and you can attach it to the laptop. So any laptop that you have in the clinic, you can attach the machine and the patient can blow into that machine and it will give you all of the values that you will need. It's of course not as accurate as our office-built machines that we have, but it's a very good machine that you can use to follow patients with asthma. So you can follow the trend of asthma. Just like the lung function that I showed, you can show the trend, how the patient is doing with time, if the patient is responding to your treatment. So this is the gold standard, the spirometry. And as I said, there are other kinds of tests that you can use to assist in the diagnosis, but they're not as good as spirometry tests. I hope this answers your question, Ahmed.
Thank you. We will have only 2 more questions. One from Dr. Laith Qasid. Please, Dr. Laith, unmute yourself.
Yes. السلام عليكم.
وعليكم السلام ورحمة الله وبركاته.
دكتور عمار، نحن نفتخر بك ونشكرك على هذه المحاضرة وعلى هذا التقديم. وأنا أشوف أنه الطلاب اللي هسه يسمعوك راح يشوفوك ويشوفوا القدوة ويكونون متقدمين بهذه الأشياء وبهذه الأمور، وإن شاء الله الخير للكل، وسلامي للأهل والعائلة والوالد. شكرا.
شكرا جزيلا دكتور ليث، وتشرفنا نسمع صوتكم، وتحياتنا للأهل ولحضرتكم أستاذنا العزيز. وطبعا هي هاي الغاية من تقديم هذه المحاضرات، هي إنه الجيل الجديد يعرف وين يركز المجهود لتحسين من صحة الطفل العراقي والمصلاوي خاصة علاج الأمراض المستعصية والمزمنة واللي ممكن تؤدي بالحياة. وأنا بالعكس أسعد لإعطاء مثل هذه المحاضرات، والكلام عن الربو عادة يأخذ وقت أطول جدا من هذا، فلهذا حاولت أن أستعجل بالمحاضرة قدر الإمكان لأن أعرف وقتكم ثمين جدا خلال هذا الوقت. بس أمنيتي بكل الطلبة أنه يكونون حريصين جدا على صحة الناس، خاصة الأطفال في مجتمعاتنا، لأنه هم هذول مستقبل البلد. وكل الدراسات أثبتت أن الصحة الجسمية والذهنية للأطفال هي اللي راح تحسن من مستقبل البلد إن شاء الله. ونحن أنا يعني ما أقول إنه نحن نتمنى إنه نكون قدوة، لأنه أنتم القدوة للطلاب، بس نحن نحاول قدر الإمكان إنه نساعد في أي شيء ممكن نطيق عليه. أنا عرضت جزء من البحوث اللي أعملها، إنه هو هذا أن التركيز هو على البحوث. عندي مركز أبحاث ولو ما كثير، يعني عندي 6 باحثين بالمركز يشتغلون على أبحاث الأمراض الرئوية في الأطفال. فأعتقد إنه هذا واحد من الأشياء، بالإضافة للسريرية، المعلومات السريرية. الطلاب أيضا يجب أن ينظرون إلى البحوث وكيف قراءة البحث العلمي، وأنا مستعد دائما لدعم أي طالب أو تدريسي عنده أي سؤال، خاصة له علاقة بالبحوث العلمية في الطب أمراض الرئة في الأطفال. والكونتاكت انفورميشن موجودة عند دكتور أسيد، دكتور نزار، دكتور نشوان، موجود عندهم الإيميل. فإذا أكو أي سؤال أو أي شيء ممكن نساعد به ممكن تبعثون لي الإيميل وأنا ما راح أقصر إن شاء الله. بس أمنيتنا كبيرة بالجيل المستقبل إنه يكونون على قد الثقة بهم إن شاء الله.
إن شاء الله. شكرا دكتور عمار. وطبعا إن شاء الله يعني احنا نتمنى انه تكون هذه يعني هي يعني الباكوره والبدايه، وان شاء الله تكون هي المفتاح للتوصل المستقبلي، وان شاء الله تكون لنا لقاءات مستقبليه يعني باذن الله تعالى. دكتور اسيل حاب ايضا يشارك، رئيس فرع الاطفال بكليه الطب. دكتور اسيل تفضل.
نعم شكرا. السلام عليكم دكتور عمار.
اول شيء دكتور اسيل.
قاعد اسمعك دكتور اسيل.
أشكرك دكتور عمار على المحاضرة الرائعة، يعني شكرا على وقتك اللي أخذناه من عطلتك، ويمكن غيرنا الموعد أكثر من مرة. شكرا على تعاونك و your help. يعني I'm very happy with this lecture أنه تمت، وأتمنى يكون في المستقبل يكون بيناتنا تعاون ومحاضرات أخرى. سؤالي هو، قرأت بعض الريبورتس، يمكن هي موضوع قديم ولا زال يستخدم، عن ال desensitization therapy أو for asthma. Is it effective يعني هذا desensitization? Is it used in America?
شكرا جزيلا دكتور أسيل على الدعوة أولا، وعلى الجهد الكبير اللي عملته حضرتك لتقديم هذه المحاضرة بالوقت المناسب اللي يناسب الجميع. وشكرا جزيلا على السؤال، وشرفت جدا بمعرفتك، خاصة أنت أيضا معرفة من قديم، خاصة مع جدك الله يرحمه، نحن نعرفهم جدا، كانوا جيران بيت جدي. وشكرا على السؤال، سؤال مهم جدا طبعا، ويسألون جدا مرضى دائما عن علاج الاميونوثيرابي، والجواب طبعا أصعب جدا بالأطفال من الكبار، خاصة بالأطفال اللي أقل من 2 سنين من العمر، لأنه the immune system is not mature enough. So we usually don't do this allergy test that I mentioned before the age of 2. Usually we do them after the age of 2. We use the desensitization test, both the sublingual and the subcutaneous test, usually for children who have either mono or oligo sensitization. So they have only, they're allergic to only one factor that we have treatment for, or up to 4 factors. We use the immunotherapy for them. Because if the patients are allergic to like 10 or 20 aeroallergens, then desensitization toward one of them will not change anything in the therapy, because the therapy is pretty labor intensive. So It needs very frequent visits. There's risk of anaphylaxis and death with those treatments, especially for patients who are severely allergic. And they're very costly here. So the patient is allergic to 1 to up to 4 factors. We usually do sensitization. Depends on the factors that they are allergic to. Some of them we have sublingual, so something that we give under the tongue. Usually the first 4 doses we do it in the clinic with the anaphylaxis precautions, full anaphylaxis precautions. So it takes 6 hours of clinic visit. But the subsequent doses, when we go up on the dose slowly, if the patients, older patients or the families are well educated, they can do it at home. For the sub-acute treatment, we do it in the clinic all the time. Because you need to give it in a very particular way to avoid IV infusion of this allergens that can induce fatal anaphylaxis. So 1 to 4 allergens that we have treatment for, we do desensitization therapy. The problem with desensitization is that you need to keep the children on maintenance therapy. So even if you desensitize them, you need to keep them on monthly injections or sublingual treatments for a very long time to keep them desensitized. Some of the allergens, after you stop the desensitization, they'll become allergic again, and you have to start everything from scratch. So it is useful in selective patients, especially those who develop near fatal asthma for mono or a couple of allergens that you cannot avoid. But for most of the patients, it's not the best treatment for them. But it is available, it's very useful in selective patients, and can give you very good results if you can avoid intensive care unit or death because of asthma.
شكرا جزيلا دكتور عمار. احنا نشكرك جدا بالنيابه عن عماده كليه طب نينوى. نتقدم بالشكر الجزيل لحضرتك لاتاحه الوقت لنا للحصول على هذه المعلومات القيمه، والشكر ايضا موصول للدكتور احمد والدكتوره روى على محاضرتهم القيمه، وشكر ايضا للحضور جميعا من اساتذه ومن طلبه، وان شاء الله نلتقي قريبا على محاضرات علميه قادمه. شكرا جزيلا للجميع. شكرا.
نشكر الدكتور مؤمن جنيد، عفوا نشكر الدكتور مؤمن جنيد المعاون الاداري لحضوره ولجعل هذه الفعاليه ممكنه. نشكره شكرا جزيلا.
شكرا جزيلا، بارك الله بكم، واقدم شكري العميق للاستاذ الدكتور عمار، وبارك الله به على هذه المعلومات القيمه وعلى اتاحه الوقت في اثناء عطله العيد. بارك الله بكم، وان شاء الله الى مزيد من اللقاءات العلميه. بارك الله بالجميع، شكرا جزيلا.
ان شاء الله. شكرا جزيلا جميعا، كل عام وانتم بخير وتصبحون على خير.
كل عام وانت بخير، تصبحون على خير.
شكرا جزيلا. شكرا جزيلا دكتور عمار.
شكرا دكتور.